All right, so we're going to talk about blisters. These are important things in the skin that we see. Basically, there are two types that we see, both the intraepidermal and subepidermal type. And this is for those of you in the room who are pathologists or dermatopathologists primarily. When a dermatologist sees a blister in the skin, it's a red flag, and they're going to take a biopsy of it, and they're going to be concerned about pemphigus or pemphigoid very commonly. And these are some of the mechanisms of intraepidermal vesiculation. The three most common are spongiosis, ballooning, and acantholysis I talked about before, and then cytolysis where the cells disintegrate, and then a couple others, epidermolytic hyperkeratosis. And we'll cover most all of those in this talk. So ballooning degeneration, and most of these, when you think of ballooning, you should think of viral vesicular dermatitis. So we talked about the ORF case we saw a minute ago. Hand, foot, and mouth disease is another disease that's caused by viruses. It's caused by these Coxsackie viruses. And there's actually been a relatively recent isolation of aggressive form caused by type A6, where they get extensive involvement in onychomydesis, mucosal erosions, and this one caused by enterovirus that actually was seen in Cambodian children, actually fatal in a number of cases. So important to remember that. We look at this under the microscope. We see the ballooning. I'll talk about it in a minute. The classic pattern are these lancet-shaped acral vesicles, and they're also seen in the mouth. This is one of those more aggressive forms that was not involving only the hand and feet, but also the glabrous skin, and they can occur over a widespread area. And this is the biopsy of that. You see the, again, blister. It's an intraepidermal blister, and then at higher magnification, you see the cells are swollen. So this is ballooning, and when these little balloons in the epidermis pop, they leave these little residual amounts of the cell membrane here, and it forms this little lace-like reticular network, and we refer to that as reticular alteration. Reticular means net-like, and that's very characteristic of ballooning degeneration, very characteristic of what we see in these viral vesicular dermatitis. So anyway, just remember that. Necrolytic migratory erythema. Now this is in the family of the deficiency diseases, or this is the one that's associated with zinc deficiency, but you can see the same thing when they have glucagon secreting tumors of the pancreas, same thing when you get biotin deficiency. All these can appear kind of similar to one another under the microscope. They get a psoriasiform dermatitis that's associated with this very superficial epidermal pallor, again with ballooning degeneration. So all of these look alike. And this is a little kiddo that had acrodermatitis enteropathica. And this is what that biopsy looked like. Again, notice the extensive ballooning degeneration of the epidermis with somewhat of an infiltrate in the dermis of lymphocytes and perhaps a few neutrophils. As time goes on, you actually get some parakeratosis, and eventually the ballooning kind of goes away, and you're left with mostly just a psoriasiform dermatitis. But early on, it looks very characteristic, where you get this ballooning degeneration with parakeratosis and an overlying basket weave cornified layer overlying that with a variable infiltrate. Now, hydroestivale, this is in the family of photodermatitides. There are about 3 or 4 conditions that can give you this similar pattern, both clinically and histologically. It's seen in sun-exposed areas. You get these blisters, they get scarring, you get spongiosis, and again, ballooning degeneration with epidermal necrosis. Here's these little erosions seen in this child on their upper face here, and perhaps even one on the nose there. And once again, ballooning. Okay, now this does not have any intracytoplasmic or intranuclear inclusions, but this lesion generally tends to occur pretty quickly. You get the ballooning degeneration here with the overlying basket weave cornified layer, and you'll need to kind of correlate this with a history of sun exposure. And so this is what you see when you see these conditions like juvenile springtime eruption, hydroestivale, hydrovacciniforme. They all kind of give you this same pattern of prominent ballooning with a variable infiltrative lymphocytes and usually overlying normal cornified layer. I've already talked a little bit about this before in the first talk. Parapoxvirus infections, again, ORF, Milker's nodule. There are a lot of other different types of parapoxvirus diseases that you can read about in the literature. These all tend to give you these prominent epidermal hyperplasia with intercellular edema, pink inclusions, and a dense infiltrate in the dermis with prominent edema. So here's an example, again, this sort of boggy plaque on this guy's hand. Another example. And another one here. So these, as you can see, can simulate pyoderma gangrenosum or other things, Sweet syndrome. The biopsy usually shows this epidermal hyperplasia, again with the pallor, and as we go to higher magnification, we're going to see there's ballooning there, and usually a very, very dense infiltrate. Neutrophils, lymphocytes, some eosinophils in here, And all of this is ballooning degeneration once again. And if we look at real higher magnification, you can see some intracellular inclusions in here. These are the viral products of the Parapoxvirus infection. And you see the very dense infiltrate there that's admixed. And this is an electron micrograph. These things kind of look like bread loaf. So if any of you guys are taking the boards, if they show you a picture of this, it looks like a bread loaf like this, it's one of the poxvirus infections. And it looks pretty similar to what you see in molluscum or any of these parapoxvirus conditions. Now, epidermolytic hyperkeratosis, this is another reaction pattern that can be associated with blisters. There's several different clinical forms. The widespread form is known as congenital bullous ichthyosiform erythroderma. There's also these systematized forms that give you these interesting names like ichthyosis hystrix, like a porcupine. It can involve the palms and soles. You can get solitary lesions, epidermolytic acanthoma. This lady had this widespread systematized epidermal nevus, ichthyosis hystrix here. And then you see this linear pattern here in this lady. And this biopsy all showed the same thing. This was the epidermolytic hyperkeratosis, congenital widespread bullous ichthyosiform erythroderma. And if you look at this under the microscope, you get this intraepidermal vacuolar degeneration with pycnotic nuclei, hyperkeratosis. This is due to a keratin 10 gene mutation. And all of these look the same. So you can't really tell which one you're dealing with unless you have clinical correlation. So that's going to be a recurrent theme you're going to hear about over and over again in this talk, is that you have to have both the clinical as well as the pathology in many of these cases to make the diagnosis. So here you see the classic epidermal reaction pattern of epidermolytic hyperkeratosis. There's this dissolution, if you will, of the keratinocytes themselves with these little granules within them and the overlying hyperkeratosis. Now, the next thing we're going to talk about are the intradermal acantholytic dermatoses. These are where you get separation of the cells from one another. And these can occur in several different ways, either due to infections, autoimmunity, hereditary, or other. They can be superficial. They can involve the entire epidermis. They can be with dyskeratosis or not. And the first group we're going to talk about are the Pemphigus group of diseases, foliaceous, Fogosylvagium, Pemphigus erythematosus. These are widespread diseases usually, and they're associated with these extensive erosions with extensive crusting. When we look at these under the microscope, we see a subcorneal or intragranular cleft. And this is a nice example. We talk about the so-called cornflake scale. It's really a scale crust. And if you were to look at this under the microscope, you see not only serum and parakeratosis, you also see some acantholytic cells. The chest is a common site of involvement. And here you see a biopsy that shows the acantholysis, and there's no cornified layer because it's been sloughed away, because it's no longer adherent to the skin here. So this is, again, superficial pemphigus. Notice that the lower part of the epidermis is normal, affecting only the upper part here. And a variable infiltrate of lymphocytes. Sometimes you'll see some eosinophils. If you look at it in immunopathology, you're going to see deposition of immunoreactants between these cells in a very high percentage of cases. It's due to desmoglin 1 or plakoglobin. And here you see in immunofluorescence, you get this nice chicken wire pattern, usually seen in the upper part of the epidermis, but sometimes in the lower part as well. There are certain drugs that can cause this, penicillamine, captopril, rifampin. And then there's a couple of other types of superficial pemphigus. Erythematosus, which is it's basically kind of a combination of lupus and pemphigus foliaceus. And then Brazilian pemphigus, we now know carried by the black fly, the Simulium fly, and it's probably an infection. So Fogo de Chao, has probably been to that restaurant. Well, Fogo means fire. Well, Fogosylvagium means forest fire. So these guys are going out in the woodlands, they're getting bitten by the fly. They come back with this, they felt like their skin was on fire. And this is what these guys look like. They've got this diffuse erosions. Looks pretty similar to superficial pemphigus. So this is just occurring down in Brazil. And if you were to biopsy this, it pretty much looks the same. Now this is distinct because notice that this is in a sun-exposed area. So it's got that nice classic photodistributed area. This is the so-called Pemphigus erythematosus or Sinner Usher form of superficial pemphigus. So this is kind of a combination of lupus plus superficial pemphigus. Notice it's also got that branny cornflake-like scale. And here you see a biopsy of this. You've got this very superficial blister in the intragranular area here with the acantholytic cells. And one other pearl about looking at the acantholytic conditions is that they can involve the follicles. If you see Grover's disease, for example, usually doesn't involve follicles. If it's a real, true acantholytic process, it's going to track right down into the hair follicles. So that's very helpful when you're looking at it under the microscope. Now, paraneoplastic pemphigus, again, important to recognize this. It's almost always associated with mucosal involvement. The interesting thing about this is it can give you a lichenoid histology as well as a vacuolar histology and the acantholytic histology, so it's a little bit different. And these people almost always have some kind of underlying lymphoma or thymoma, something like that. More commonly the lymphoid rather than the solid neoplasms. And if you look at the immunofluorescence, they actually have indirect immunofluorescence positivity to these simple epithelia, like rodent bladder substrate. So that kind of helps you to define this. So this guy had a lymphoma, developed pemphigus, involved his mouth, and also involved his skin, and had features can look very much just like regular garden variety Pemphigus vulgaris, but they can also sometimes have a lichenoid histology as well. This one did not have that, but looked pretty much just like regular Pemphigus. There are bacteria that can induce subcorneal processes, staph scalded skin syndrome and bullous vitiligo. The pathophysiology here, you've got organisms that produce an exfoliative toxin. They rupture, they produce these honey-colored crusts, and then you get this subcorneal vesicle with neutrophils looking kind of like this on clinical bases. And notice all this crusting over here after these areas had ruptured. Another example here. And if you look at this under the microscope, you see this nice example of this very superficial blister with neutrophils in the blister space and some acantholytic cells. Usually not as many as pemphigus, but you can get quite a few in some cases. So you really need immunofluorescence to distinguish these. You can do a gram stain. Sometimes you see bacteria, sometimes you don't. So that's important to remember as well. And then staph scalded skin syndrome, you don't even actually have to have any bacteria there at all. These can have infections usually seen at a distant site. They release this exfoliative toxin, it circulates through the body, and then it causes the acantholytic process at a diffuse area. So this guy had staph scalded skin syndrome. This little baby had the same sort of thing. And again, you get this very superficial cleft here with neutrophils, subcorneal pustule, subcorneal cleft, sometimes with some underlying epidermal necrosis as well. Pemphigus vulgaris, probably the most important one of these to remember because this can be fatal in many cases if you don't diagnose it and treat it properly. It can be associated with underlying diseases also like thymoma, lymphoma, and sometimes lupus. This is the split here is occurring more deep, occurs just above the level of the suprabasilar area. Mucosal involvement here, a classic setting of an older man. Again, you get the crusting on his eye in this situation. You also have involvement in his mucosal surface, his mouth, and then the buttock area involved. So this is all Pemphigus vulgaris. And if you look at this under the microscope, this guy actually had a blister that was pretty much full thickness that had reepithelialized, was getting a new suprabasilar blister occurring in this location. So blister here, reepithelialized, new blister forming here. And then another pearl, here's another area that shows a more classic sort of suprabasilar cleft here with the villi or the tombstones here. Always look at the edge of your 4mm punch biopsy because you're getting kind of almost an artifactual Nikolsky's or Asbo-Hansen sign there. So you may not get as much blistering in the center of the area, but at the edge of the punch, it's very helpful to look there because that may be a site that's more prominently involved than the center of the punch. Mucosal pemphigus sometimes looks a little different when you biopsy that, and you sometimes just see a cleft like you see here. It's kind of subtle. Again, notice the overlying epithelium is pretty much normal, so this is Pemphigus vulgaris. And then immunopathology, again, you're looking at desmoglein 1, desmoglein 3, sometimes desmoglein 3 and 1, and then activation of this plasminogen activator, which is what causes it, and it's associated with some of these HLA subtypes. And here's a nice example, again, of that chicken wire pattern of Pemphigus vulgaris. Notice it's not only in the suprabasilar location, it's pretty diffuse throughout the epidermis. Pemphigus vegetans, it's kind of like Pemphigus vulgaris, it just gets marked epidermal hyperplasia. So that's kind of the way to think about it. They get these verrucous crusted areas, and these areas often usually at the angles of the mouth. He's got some inside his mouth, as you can see here. These very heaped up, crusted verrucous areas here in this groin. And you get these little intact blisters here with some neutrophils. And then you see these nice clefts here and the overlying epidermal hyperplasia, which correlates with that verrucous epithelial hyperplasia. This condition will often be associated with eosinophils in the infiltrate too, interestingly enough. And you may get these little clusters of eosinophils within those blister spaces in the epidermis. Hailey-Hailey disease, benign chronic familial pemphigus. It's an autosomal dominant process, usually seen in the intertriginous areas of the body, axilla, neck, groin. These are very flaccid vesicles that rupture with the erosions and crusting. You get the so-called dilapidated brick wall. One way to think about this from a clinical perspective, it kind of looks like wet toilet tissue. And here's the axilla. It's classic involvement. Another example, you see all this maceration here. And when you biopsy this, you get this very diffuse acantholysis extending throughout the epidermis. So it's not just the suprabasilar area, it's involving the roof as well as the base of the blister. So diffuse involvement. You may get some dyskeratosis, but you don't have to, but you almost always get this diffuse involvement, not present only just above the basal cell layer. Now there's some other disorders that give you so-called acantholytic dyskeratosis, different reaction pattern, and there's only about maybe 5 or 6 diseases that are associated with this. Dariase, Grover's are probably the 2 most common, warty dyskeratoma, certain epidermal nevi, etc. So once again, when you see this histologic pattern, you have to correlate it with the clinical findings. This is a Dariase disease, an autosomal dominant process, usually associated with these verrucous crusted papules in the sebaceous areas of the body. The palms and soles are commonly involved. You see the very classic acantholytic dyskeratosis, and you get negative immunopathology. So these are some examples of Dariase. If you actually were to take your hand and rub it across this, it would feel like you're rubbing it across a nutmeg grater. Very, very rough, crusty, rough type appearance to the skin. This guy's got very severe verrucous involvement of his face. These are the little palmar pits that you see clinically quite commonly, and if you rub your hand across these, this also feels very rough, like you're rubbing a Nestle's Crunch Bar or a nutmeg grater. They get these white and red streaks with distal notching in the nail, very classic for Dariase. And then if you biopsy it, you see the classic findings of acantholytic dyskeratosis. The cells are falling apart, and then the cells are dyskeratotic. Now these are the so-called chorones and grains. All that means is a grain is an acantholytic dyskeratotic parakeratotic cell, and a chorone is an dyskeratotic acantholytic granular cell, as you see here, or spinous cell. So there's nothing specific about this. It's seen in any of these diseases that give you acantholytic dyskeratosis. So it doesn't mean Dariase. You can see it in Grover's, you can see it in warty dyskeratoma, you can see it in any of these diseases. So you must have clinical correlation to make the diagnosis. Or here you see a high magnification of these little these grains here and these chorones here. Okay, Grover's, again, it may histologically look like Dariase, but it's a totally different setting. It's usually a pruritic eruption occurring on the trunk or extremities of older men, although occasionally you'll see it in people that don't meet that criteria. We've seen a cluster of these in younger women, interestingly enough. We don't know exactly what causes this, but it tends to be worse with heat and sweating. And if you do get FAD, it doesn't tend to involve the follicles, so that can help you to distinguish it from Dariase just looking at it under the microscope. One interesting thing about it is you can see some other patterns. You can see some patterns that look like Pemphigus vulgaris or superficial pemphigus or Hailey-Hailey or even spongiotic dermatitis under the microscope. Here's a classic clinical of a patient with Grover's disease, an older man with these itchy, scaly, crusted papules on the trunk and extremities. These usually get sent in to us as roulette bug bites or folliculitis, something like that. And then a biopsy is done, and it shows changes that usually look pretty much like those that I just showed you with Dariase, focal acantholytic dyskeratosis. And in this case, there's no involvement of hair follicles, which kind of helps you to make the diagnosis. If you see more than one pattern, if you see this in one area and superficial pemphigus in another area, that also favors Grover's over one of the other diseases. Now, the next pattern to look at is sub-epidermal blistering disorders. These are, again, important conditions. These are where the blisters are occurring beneath the level of the epidermis, and these can be caused by either mechanical or immune processes, and sometimes even other things. This is an important thing for people, residents, and others taking board examinations. You need to know this very, very well because there are certain diseases that target certain areas of the basal membrane zone. Bullous pemphigoid occurs quite high in the basal membrane zone area, whereas things like epidermolysis bullosa and some of the epidermolysis mechanobullous disease occur way down here at the level of the anchoring fibrils and whatnot. So depending on which level of the basal membrane zone is involved, you're going to get different levels of involvement and scarring and other things. So pemphigoid basically is probably the most common of these that we see. Antibody, it's an autoimmune process directed to desmoplakin or this 180 kilodalton bullous pemphigoid antigen 2, which is directed at type 7 collagen. And these antibodies deposit, they fix complement, they get blisters. Usually seen in older individuals. Early you'll see urticarial lesions, and then later on you'll see these tense blisters. These are some examples of the urticarial stage of bullous pemphigoid. Urticarial means it looks like urticaria, but it's not waxing and waning, it's fixed, and that's important. Here you see urticarial lesions that they've got a couple of blisters here, and then one that's got these tense blisters adjacent to these urticarial plaques over here. And under the microscope, you'll see a superficial band-like infiltrative lymphocytes and eosinophils, and then you'll eventually get a blister. So here you see a subepidermal blister, and notice lymphocytes and eos. So if you see this pattern, you can suspect bullous pemphigoid. It's not absolutely specific for it, but it's highly suspicious for it. And you can usually, obviously in a case like this, you'd recommend immunofluorescence studies be performed. You'll usually see a linear IgG and C3 in these patients. It's a nice smooth band like you see here. Up to 90% or more of patients will have this. We'll see occasionally patients that don't have it, but that's relatively rare. Okay. Now, there are some variants where you see minimal inflammation. Again, indirect inflorescence also very strongly positive. So again, if you get a false negative, consider doing ELISA or another study. And then if you're concerned about the diagnosis of EBA, you can do a salt split skin study. Now, EBA is different. There's several different variants of this. There's one type that can look like a mechanobullous type. The other type will look like pemphigoid. Again, these can be associated with underlying disease like lymphoma or GI disease, so you want to make sure that you distinguish these. This guy's got the form that kind of looks a bit more like a scarring, like a classic mechanobullous EB. He's got scarring on his hand, so he doesn't look as much like pemphigoid. Notice the lack of a lot of prominent inflammation in the background here. And again, there's several different forms here. This pattern was one in which there was almost no inflammation, so this looked pretty much more like in a mechanobullous form of epidermolysis bullosus, so a cell pore infiltrate with some scar here. And then this form where you do have some inflammation with some festooning that had some eosinophils. So this one looked a lot more like bullous pemphigoid. So in order to distinguish these two, you may have to do some additional studies. One thing that you can do is you can actually do a salt split skin technique. Again, these are different antibodies. These are directed to the anchoring fibrils of type 7 collagen. They both have linear IgG and C3, both pemphigoid and EBA. If you get multiple immune reactants such as IgA or IgM, that kind of favors favors EBA over pemphigoid. If you get C3 alone, that favors pemphigoid. And then you can do an look for circulating type 7 collagen, which is present in over 50%. Now, the salt split skin technique is helpful. Basically, here's a direct immunofluorescence looking very much like pemphigoid. Salt split skin occurs in this location here. So if you actually do an immunofluorescence study, you'll actually find that it binds to the base of the blister of that salt split skin if it's EBA, and to the roof if it's bullous pemphigoid. I'm not going to read this whole chart to you. It's in the handout that you have on your jump drive in your registration packet there. But you ought to know this, especially if you're studying for the boards, because they love to ask these kind of questions. So here's that salt split skin. You see the binding is present on the roof of the blister here. This is one where there's some binding on both the roof and the base. And this was binding on the base. There's the roof of the blister here, so this was EBA, and that's helpful. Now, if you don't have salt split skin in your laboratory, if you do have a blister, you can actually use type 4 collagen, and the opposite of that is true here. The binding in the base will be at the base of the blister with type 4 collagen if it's bullous pemphigoid, because that blister in bullous pemphigoid is occurring much higher than in EBA, which occur beneath the level of type 4 collagen. So that's a helpful thing you can do if you don't have a salt split skin study to do. DH, very pruritic process, probably the most pruritic disorder of mankind. People used to commit suicide before we had good drugs for DH. Now it's treated nicely with dapsone. It's usually seen in a young to middle-aged individual. They get these symmetrical grouped papules and papulovesicles. It's very unusual to get an intact blister in DH because the patients are so itchy, they'll just scratch them all away. Here you see some urticarial lesions of dermatitis herpetiformis, relatively rare. So early urticarial lesions of DH, and this is a process associated with gluten-sensitive enteropathy with circulating anti-endomysial antibodies. So again, this is something you can order in the laboratory. There's IgA here that's directed to these proteins, and it's associated with these HLA subtypes. And they have a gluten-sensitive enteropathy in the vast majority of cases. Here's normal duodenum here, and then this is celiac disease, where all of these villi are flattened and there's prominent inflammation. And this is a small bowel study which shows this rapid transit of the barium here. This is all of it's in the should still be here. This is just a few moments after they drank this. It just went right through into their large intestine. If you look at this under the microscope early, you'll see a sparse infiltrate with some neutrophils. Later on, you'll get these collections of neutrophils at the tips of dermal papillae. So here we see an early lesion of DH with these neutrophils with no blister yet. So this is very characteristic of dermatitis herpetiformis. And then later on, again, more classic pattern where they got all these erosions because they're so itchy and they've been scratching this. Notice it's occurring in this very classic extensor location here, the presacral area, common site of involvement. And then now we have a blister where we have neutrophils and these clusters at the tips of these dermal papillae. Beautiful example of DH. There are also some eosinophils here. Later lesions of DH will get EOs also. So if you read in the textbooks that DH is associated with neutrophils, that's true early, but later on it actually will get some eosinophils as well. If you do immunofluorescence, you get these granular deposits of IgA at the tips of dermal papillae in a high percentage of cases, 95%. You can get some false negative. Sometimes it's just a small amount of deposition. And sometimes if the patient's been on a gluten-free diet, they may actually get some negative findings here too. So if you want to get a positive immunofluorescence with DH, have them eat a couple of slices of bread a few days before, and then do it. If you're sadistic, you can get a positive result there. And here you see a nice example of IgA at the tips of these dermal papillae here. Now, linear IgA bullous dermatosis, there are two types. An adult that's associated with drug ingestion. These are some of the drugs that cause this. Vancomycin is the most common one. And then the childhood type, which occurs in kiddos, usually goes away by the age of 8. So this is a kid, used to be called chronic bullous dermatosis of childhood. We now know it's basically the same process as linear IgA bullous dermatosis. And if you look under the microscope, there's this nice linear deposition of IgA. They get neutrophils. It looks a lot like DH histologically. But when you do the immunofluorescence, you'll see the linear IgA. This was an adult. She had taken vancomycin for an infection and got this reaction that had abundant neutrophils here beneath the epidermis. And then the immunofluorescence finding with this nice linear band of IgA at the dermal-epidermal junction. So nice example of LIGA. Bullous lupus, these people almost always have known lupus. It's not usually presenting finding. Usually they've maybe had known lupus, went out in the sun and got a flare for some reason, or maybe they went off their steroids. They're usually quite ill. And here you see this guy's got these small papular vesicles on his face, unexposed areas. Even the mouth, the mucous membranes can be involved sometimes. This lady's very, very sick, and you should get these very flaccid vesicles here. Notice the nice sun-distributed area here. And this blister here, this was bullous lupus erythematosus. Usually this is a neutrophilic process, so it's another one of these sub-epidermal blisters with neutrophils. Sometimes you'll see some background lymphocytic infiltrate, like background lupus here, but they don't have to have that. And higher magnification, all of these neutrophils. So sub-epidermal blister with neutrophils, you think of DH, you think of this, you think of linear IgA bullous dermatosis, sometimes EBA, relatively few number of diseases. If you do an immunofluorescence here, you're going to see multiple immunoreactants at the dermal-epidermal junction, usually more of a granular pattern than a linear pattern. So here you see that in this photomicrograph. Cicatricial pemphigoid, again, there's two forms of this. There's a type that involves the mucous membranes. Then there's a type that can involve the glabrous skin, known as the Brunstein-Perry type. They get the involvement of the eye quite commonly with synechiae, can lead to blindness. They can also get mucosal involved in the mouth. Esophagus can be involved. Here you see a very thin esophagus on this barium swallow. It's a terrible disease when it involves the mucous membranes, very difficult to treat. Usually it looks kind of like bullous pemphigoid, only there's scar and tends to have more neutrophils. So here we see an example of cicatricial pemphigoid, subepidermal blister with scar formation. So if you see that, you want to think of either mechanobullous disease or you want to think of this disease. And again, neutrophils, eosinophils tend to have more neutrophils than eos sometimes in cicatricial pemphigoid with scarring. This is also due to deposition of immunoglobulin and complement of the basal membrane zone. You may get circulating antibodies here as well, directed to epiligrin. And if you do a salt split skin, this will occur both on the roof and sometimes the base in both locations. Brunsting-Perry looks a lot like pemphigoid. Probably the most important thing about this is that it can look almost like a basal cell or like a scarring process, and the scalp is commonly involved, where it can kind of simulate chronic erosive pustular dermatosis of the scalp. And we've seen some of this get sent into us as rule-out basal cell because it's kind of scarred down. They may not recognize this as a blister. They think it's a translucent papule, and then when it gets biopsied, it looks like a blistering disorder. Cutaneous porphyrias, again, there's a bunch of these. I'm not going to read all of them to you. The one that we see most commonly is Porphyria cutanea tarda. These can be seen in several different settings, both autosomal dominant or acquired. Acquired is probably the most common that we see associated with liver disease. And they give you this hyperkeratosis, is hyperpigmentation of their skin here, and they get these areas of erosion with milli on the back of their hands with or without intact blisters. And if you biopsy, they also get fluorescence of their urine, this coral pink color here. And if you look under the microscope, they usually get this sub-epidermal blister, often with many little inflammation. There's sometimes you'll see some neutrophils. We'll talk about that later. But this is a classic pattern where you get this festooning with minimal inflammation, these thick blood vessels where you get this sort of PS-positive basal membrane material surrounding the blood vessels. This festooning is very characteristic. Here you see the thick blood vessels here, classic for PCT. And you can get immunopathogenesis. You can get deposition of immunoglobulin and complements, often multiple around blood vessels and at the D junction. Here's a nice example of what we see. It's usually this kind of thick ribbon of binding with the blood vessel involvement here as well. Well, sometimes it's negative, but usually it's positive. And these are due to these abnormal enzymes in the heme biosynthesis pathway that absorb in this classic Soret band. And that's, if you're taking boards, it's, you can just pretty much bet that's going to be on there. Pseudoporphyria, these are due to drugs that patients take. Naproxen, NSAIDs are quite common. They may be due to a mild enzyme deficiency, and they look pretty much like garden variety porphyria. So you basically have to work the patient up and see whether they have this or whether they have the other one. The histologically look very similar, give you subepidermal blister usually with minimal inflammation, and then they give you the necrosis with the so-called caterpillar bodies. So that's seen both in pseudo-PCT as well as garden variety PCT. And then minimal inflammation in these thick blood vessels, so those are pretty much straightforward, seen in both of those conditions. Pemphigoid gestationis, seen in pregnancy. They get these urticarial papules, so a good way to think about this is it sort of looks like bullous pemphigoid, only it's in a person that's pregnant. So again, if you didn't get any history on this, you might think that this could be bullous pemphigoid if you're looking under the microscope, but it's seen in a young individual. The umbilicus is almost always involved with this condition, and you get these almost kind of string of pearl-like pattern of the blisters occurring on the trunk and then also on the extremities. And if you biopsy this, it looks like bullous pemphigoid, but the immunofluorescence pattern, here's kind of an urticarial lesion of one of these, is different. You get primarily complement with no other immunoreactants. So here you see the subepidermal blister, and this is due to a highly avid IgG that binds complement, this 180 kilodalton herpes gestationum antigen. So this is C3 only binding here. Now, erythematoformis, it's not an immunobullous disease. This is due to an immunoreaction that occurs. It's an interface dermatitis, and it leads to blistering in some cases. There's the minor and the major form of this, usually associated with herpes, but can also be associated with drugs. And when it gets to be widespread, then we call it TN. I like to think of it as in the same spectrum of the same disease. Here you see some early target lesions of erythematoformis. The acral skin is involved. The mucosal surfaces can be involved. Here a nice example of the target lesions of erythematoformis. And if you look under the microscope, you'll get a change to superficial perivascular dermatitis with some interface change. It can simulate a spongiotic dermatitis. Later on, it can give you extensive dyskeratosis. And in TN, you get confluent epidermal necrosis. So here's an early lesion of EM. When we talk about chronology, if you see this on day one, it really looks more like a spongiotic dermatitis. So this doesn't look like classic EM in a late stage of evolution. It looks completely different. And if you just saw this, you probably would not make the diagnosis. So you might think it's a spongiotic process early on. Notice there's no parakeratosis, no abnormal cornified layer yet at all. Really at this stage, very few dyskeratotic keratinocytes. This is getting into the Stevens-Johnson category involving mucous membranes. Now we do have some interface change with some necrosis of individually necrotic keratinocytes here and some edema with evolving incipient vesiculation. Notice the cornified layer is normal, so this disease happens so quickly it doesn't actually have time to cause parakeratosis. And now we actually have an early blister that's formed. And then later on, TN, again, possibly life-threatening. These patients end up in burn units. So this is a very serious disease when people get this. And here we're often even called upon to do frozen sections. If you just take the roof of this blister, you'll see confluent epidermal necrosis with normal basket-weave cornified layer. And the differential diagnosis clinically is often staph scalded skin syndrome versus this. You can tell this apart very readily by just doing a frozen section of the roof of this blister, because you would never see total epidermal necrosis like this in staph scalded skin. That blister would occur up in this area. So you see this, not a good situation. Those patients end up in an ICU situation. The last thing we'll kind of talk about briefly, some Bullous diseases. There's a couple of minutes of these. These are complicated conditions, but basically they're the three major forms are simplex, the junctional, and then the dystrophic forms that we see, which occur from top to bottom. Again, the Hurwitz, which is the junctional type seen in children, the simplex type often seen in people in their older age. They may not even know they have this until they go out and do a lot of walking or something, get these chronic blisters. And then the dystrophic types, which can lead to severe deformity. This was the Hurwitz type seen in a baby, again, sloughing their skin. Luckily, this heals sometimes without any significant sequelae. The simplex type, there are a lot of different forms of this. These are caused by keratin gene mutations. Again, you get these this sort of albopapuloid type here, and then the intact blister in this situation. These firm papules that occur secondary to these blisters that have formed. Again, you look at this under the microscope, the cleavage occurs actually in the basal cell layer itself. So notice there's a normal basal cell here that's kind of sheared within the cytoplasm. So this is the way to diagnose EB simplex. And then if you do electron microscopy, you can see these clumped tonofilaments here. So that's very characteristic of that. The dystrophic forms, there's a dominant and a recessive form. Again, the recessive form is a terrible condition that's usually fatal. These people get squamous cell carcinomas, and they metastasize and end up killing the patient. They get these mitten deformities of their hands and their feet like this. They lose their digits here, and they're often they don't have normal growth. If you look under the microscope, basically you don't see much inflammation, but you get the blister that occurs beneath everything with extensive scar, and then as time goes on, they develop squamous cell carcinomas in these locations here. So again, important to distinguish that off with electron microscopy. Other disorders develop with subepidermal vesiculation that occur sort of secondarily. Just a couple examples of these. Amyloid can give you blistering. This is due to the shearing of the dermis. So these are dermal-based blisters where you get amyloid, usually nodular amyloid, that fractures and you get a blister occurring down here. So this is nodular amyloidosis that gets blistering. And then ischemia, where you get situations where there's no blood flow to the area. You get hypoxia, they get secondary blisters, coma blisters, people that get ischemic for one reason or another. One of the clues to this diagnosis, if you see necrosis of the eccrine sweat units, the eccrine sweat glands are very metabolically active, so they kind of die quicker. And again, you get this blister with epidermal necrosis and usually minimal inflammation. In these ischemic bullae. These are the sweat glands here. This sweat gland here, there's total necrosis over here of these little cells here. So that's very helpful if you see that in diagnosing this. And mastocytosis. Kiddos that get mastocytomas, they get traumatized, and they can get bullous mastocytosis. This is due to mast cell disease, where you get massive numbers of mast cells that rupture, they get secondary blisters. So tons of mast cells, blister occurring secondarily. These are not classic immunobullous diseases, but there are other conditions where you can get blisters, and this is a Giemsa stain with just every single cell is a mast cell here. So don't rub these. If you see somebody that's got a mastocytoma, they can actually go into shock. So if you get somebody, a kiddo like this, don't rub it. The last thing we'll talk about, interestingly, is ORF. It's been reported to cause an autoimmune blistering disease. We started with ORF, we'll end with ORF. And basically there's some erythematoformi-like lesions that can develop in this, but they have positive IgG and C3. We're not sure exactly what's happening here, but this guy had ORF here, like we've already seen before. And they also had erythematoformia-like lesions that developed with this, but interestingly enough, it wasn't erythematoformia. It had positive IgG and C3 like Bullous pemphigoid, interestingly enough. So what we're thinking, this guy had ORF that developed the site of a grease burn, and these are the bread loaf viruses again that you need to know for the boards. And they also had this EM-like pemphigoid-like process, interestingly enough. So we don't know what that was due to, probably some kind of epitope spreading, but just showing you that you can get interesting immunobullous diseases even occurring secondary to viral infections. So very important topic, one that you're going to be called upon to diagnose both clinically and histologically, and you do need good clinical correlation to make the diagnosis.